So this is a 74-year-old gentleman with history of, with all the normal risk factors we have in the region, who presented to the outside hospital with chest pain and shortness of breath. He was diagnosed with an unSTEMI and pulmonary edema. EKG showed an old infraposterior MI, high troponins. He was requiring some face mask oxygen, and he had cath showing 3-vessel disease with an echo reported EF of 30%. So he was transferred for urgent cabbage, not cath, sorry. The center he was at didn't have cardiac surgery. So upon arrival at night, the patient was in mild distress, but we didn't have the cath images available. He was treated with diuretics initially. And then the following morning, he decompensated with increased dyspnea, became hypotensive, MAPS of 50, basically going into cardiogenic shock. He was started on vasopressors, and his bedside echo showed an EF 30% with severe MR. He was taken emergently to the cath lab for mechanical circulatory support, and because we didn't have cath images. So as you can see here on the images, he's got horrible disease, some left main disease, occluded circ, not much collaterals to it, and an ugly prox LAD as well with diffuse LAD disease. His right was also occluded without much collateralization distally. So kind of 2 CTOs, not well collateralized, and a tight prox LAD. His hemodynamics were severely impacted. His index was less than 1.5, so an Impella was put in at that time, stabilization until we can kind of make a decision. So his baseline hemodynamics was bad shock, index of 1.4, MAP of 50. After the Impella, it improved, index to 2.4. And then over the course of the next 2 days, patient clinically stabilized. The shock liver, he had LFTs to the thousands, improved. He was diuresed. He avoided intubation. Renal function stabilized. But the Impella, as we weaned down from P8, was not able to be successfully weaned. So this is the TE images done, again, 2 days after the cath, with the Impella in place, showing severe MR, functional. You can see the kind of Impella still there. And pretty central with a restricted P2 segment here, pretty relatively broad jet against severe MR.
Okay, thank you, Mahmoud. I'll just interrupt here. So Dr. Mohammed Rashidan, as a surgeon in the MDT team, would you consider offering surgery for such patient, cabbage and mitral valve repair in such case or not? At the end, he had a kind of surgical anatomy for the coronaries.
Okay, thank you for the question. First, let's put all context together. This guy is 74 years old. He presented with shock, and now he's has multi-organ failure. He has a renal derangement, shocked liver. His MAB was low. He was in inotropes, taken to the cath lab, put in an Impella. And now we cannot wean him from Impella. On top of this, he has severe mitral regurgitation, and his ejection fraction in 30, 20. Yeah. Okay. So if you put all this together, his mortality rate will be, taking him for cabbage and mitral, will not be less than 30%. So I would really be hesitant to take him for surgery with all this put in together. But what I would suggest as a part of MDT team that we should go try to fix his coronaries with PCI, treat him medically, and then reassess the mitral valve within after he's been fully medically treated, and then we can tackle this again with the less invasive approach, TEER or other modalities.
Thank you.
Mohammed, how about you in terms as an interventionalist? So Anas has suggested PCI and then reassess. Would you plan all of the above, or would you kind of go stepwise?
The approach of PCI and then reevaluate the mitral valve is I think the best approach, because he's, as Dr. Mohammed mentioned, he's a very high risk for surgery. And sometimes when you revascularize patients, you actually, the mitral valve can improve as well.
So in terms of our MDT discussion, there was basically the patient was a poor candidate for surgery because of, again, the risk, and on top of it, bad targets. So you can't really see a circ target. There's no RCA target of good. So it's basically just an LAD. So we planned a stepwise approach, but not a reassessment. We weren't going to wait too long. Also because the patient was really Impella dependent at this point. So this kind of just showed the PCI was done. We targeted only the LAD, so it was stented. I'll skip through it. Sorry.
So you can comment here. Go to the images, Dr. Traina.
Sorry. Okay.
So you're vascularized the LAD, right?
Oh, the LAD only.
Okay.
So we just did the PCI to the LAD, the clear, reasonable target, and then the circ, the wire didn't cross. But again, it was a gentle attempt. It wasn't a full CTO 3-hour case. We wanted to get in and out. So without able to cross the circ easily, we just treated the LAD. He remained on the Impella, and then we brought him back the next day. So at this point, patient had stabilized after the LAD. Impella was weaned down a little bit, and this is in the lab at the time of the TEER, planned TEER the following day. So the question is, I guess, how should we approach this with the Impella in place?
I think we'll ask Anas to comment on the mitral valve anatomy and the best approach to tackle this. And we also have an Impella in place. Would that change your strategy as an imager?
Can we have the...
All right. So,
Dr. Anas, please, the camera.
yeah, so this is TE at 10 degrees, so it's almost equivalent of the 4-chamber view, but just more focused on the LV at this point. And you can see that there's a fairly severe, first of all, if you look at the two leaflets, they're kind of tented. They kind of form a V shape, so they're apically tented. The other thing that we can see is that you can see the Impella just coming on the left side of the screen, just coming out of the LVOT. And you can see that there is quite a significant mitral regurgitation. There is a poor coaptation of the leaflet, poor coaptation length, and I would even go as far as say that I cannot exclude a possible gap there. And there's a significant mitral regurgitation that's clearly quite severe. Do we have any more TE images?
We had the baseline. I can go
If
back.
you can go back, yeah, please.
Okay, sure. You want the 3D or?
No, well, go with the 2D first. Yeah, if you can play this.
Let me go back and then play it. Okay.
Yeah. So as you can see, this is a kind of almost like a long axis view. So this is almost like a 3-chamber in your transthoracic. And you can see that the posterior leaflet is quite apically restricted. The anterior leaflet is almost, you can think of it as trying to reach it, like there is anterior leaflet override. And there is posteriorly directed mitral regurgitation. This appearance is quite typical for functional mitral regurgitation. If we go to the 3D, please. And you can see on the 3D that there is a fairly wide jet. And this is typical of functional mitral regurgitation. The coaptation line is almost like has a crescent shape, and the regurgitant vena contracta almost has the same shape. The other thing is that you can see that there's a bit of a medial bias, which is also typical of functional mitral regurgitation, as you can often get more restriction of the medial side of the posterior leaflet than the lateral side. This is why often you see what we often think of as potential dropouts or indentations on the just medial to A2 in functional mitral regurgitation. All right. So in this case, we have a patient with functional mitral regurgitation that's clearly severe, with the jet that's originating centrally with a slight medial bias. The leaflet length looks appropriate to me. The only problem is that the patient has an Impella in the LV, which again, if you put a lot of metal in the LV, it's going to result in some potential imaging issues. Also, you probably need to be careful with your device as to not interact with that Impella, and that would be a major point of concern in this patient.
Yeah, and the other thought is also it becomes hard to assess your final result because it may look good with an Impella in, and then what's your final target? You know, if you get it down and then you end up with take it out the next day and it's more moderate to severe.
Yeah.
So at this time we decided patient was actually looking pretty good, so we weaned off the Impella. We replaced it with a balloon pump. At this point, the patient tolerated that. So this took about a good 30-40 minutes kind of to do this process. And hemodynamics remained stable and the MR remained very severe. So we went ahead with the case.
Perfect.
So this is kind of just the 3D images at that time. This is, you were asking about leaflet length. Here's on the left.
What was the length that you got?
0.8, 0.9.
All right. And you can see that he provided the mean gradient. Often reduction and procedural success has to be, like with MR, reduction needs to be weighed against residual gradient with these patients. But it seems like 2 millimeters is pretty good.
So this is just the showing the location of the transeptal puncture. And this is Dr. Bafadl showing me that he's happy with the location of the site of the puncture.
Right. So what device size did you end up using? So we have a patient with wide mitral regurgitation, fairly big valve. I'm sure you guys got a valve area. I'm assuming it's above 4.
Above 4.
Yeah. So if it was me, I don't know about other guys, I would, if I'm using the Abbott system, I would go with the XTW in this case. If I'm using the Pascal, I would go with a P10. And I would probably target going just at A2P2 or maybe just immediately medial to A2P2 is where I would go.
Exactly what we did. XTW going central, trying for single clip. And this is kind of the device being put in here, again, slightly medial to the middle of the P2 segment.
Yeah, yeah.
And this is kind of grasped with good grasp. You can see on the posterior leaflet there on the right, good grasp with the anterior leaflet. And this is kind of, you want to comment on these, the tissue bridging and the grasping here, what you're looking at?
Yeah, so when he was grasping, we were seeing the grippers bouncing on the clip arms. So that's a good sign that you have good insertion. We obviously visualize the leaflets going to the center of the actual device. We see the leaflet going all the way to the apex of the device, and then when there's closure, we ensure that there is restriction to both leaflets, that there's no excessive mobility to any leaflet, and obviously we look at the tissue bridge both on 3D and transgastric. Yeah.
This is kind of the final MR images. We have basically trace residual MR at the time, again with the balloon pump. And our final mean gradient was 3 with a single clip.
Great case, amazing result.
This is just kind of what it looks like on fluoroscopy. You know, again, these procedures are primarily driven by echo. Fluoro is just a mild add-on. So patient basically was stopped dobutamine later that same day. The balloon pump was removed the following day. He was discharged home 4 days later after my optimization of medical therapy. This was about almost a year and a half ago now. He remains clinically stable without any further hospitalizations. We did not revascularize the other 2 territories, and his repeat echo shows EF 40% with 1+ MR.
Okay.
Thank you.
Thank you so much.